Hello, and welcome to Healthcare IT Today. I'm Colin Hung, and today I am joined by Ron Holder, Chief Operating Officer at MGMA. Ron, thank you for sitting down with me today.
Thanks, Colin. I'm so glad to be here.
Ron, I'm really excited to get the chance to speak with you because MGMA came out with a stat year in review, which was labeled Through Hardship to the Stars. I think the report came out recently. And I was fascinated with one particular statistic in there, especially. It was that 97% of people in the survey said that their practice was expanding telehealth in 2020. Was there a particular vector for that expansion, or did you find that certain practices were using telehealth in a certain way?
Yeah, not to be too cute about it, but basically 97+% of practices wanted to keep some money flowing in, is what happened. There were so many states and that decided to, close things down except for emergencies or whatever. And so basically practices that hadn't done any telehealth up to that point found themselves, if we want to be able to continue seeing patients at all in the next few weeks, we need to get something implemented quickly to be able to do it. And also, one practices that were doing some telehealth found them having to expand it and open up access in new and different ways to some things they weren't doing. A lot of the visits that you saw of the practices that were doing it before the pandemic was, things that were didn't really require diagnostic testing or a physical exam. There were a lot of the things that you get via discussion, with your provider, and you're telling about the symptoms and the things that you're experiencing. And so visits like that are the ones that you saw more expansion of because more providers started doing it. And if there was a silver lining at all to the pandemic with regards to telehealth specifically, it's that both providers and patients saw that there was some value to it in certain situations where, maybe both parts of the providers and parts of patients alike, for whatever reason, they didn't trust it. They valued the interaction with their provider. They saw it as a social outing, whatever, in the various aspects. They didn't want to do it. They hadn't jumped off. So it was good that patients and providers both saw that there was a place for this. And I think there will be some continuation of it post-pandemic. Do I think that it'll be like it was during the pandemic in terms of volumes? No, I think that it'll probably go back to mostly, in-person visits, but I think it'll be higher than what it was before. And it one of the things that I think really drove a lot of it is I saw different stats that said up to 3+ times as many depression cases during the pandemic. And that's something that providers can talk through. And there's ample room for even more mental health expansion for telehealth types of services. But as I said before, things that require diagnostic testing or physical exams, you're going to have something there other than just dialogue over video connection.
Well, in some ways, because of the pandemic, we were as you said, we were forced into using this modality for care, like telehealth. And whereas before there maybe have been some hesitation to use it, it certainly seems that when push came to shove, the hesitancy over technology concerns kind of went out the window. I think that was sort of a major concern at the before the pandemic was, is this going to cost me a lot of money? Is this problematic to use? Are patients really going to enjoy it? We kind of found out that, hey, it's actually all right.
Right. How can my provider, my physician, my person assess me adequately over the video channel, or how can I assess a patient over video? I need to see them. It's people like to do what they've done the most, what they're best at, and everyone has their own comfort zones from those types of relationships. So yeah, the technology one kind of went away by necessity.
And you think I heard you right that you think that there will be a little bit of a decrease once people are able to fully open up because people will want to go back to in-person visits, but that telehealth will still be there. I mean, the investments made will not be forgotten.
Absolutely. I don't think anyone's crystal ball is perfect right now to be able to say where exactly that's going to land because there's so many pieces in play that could impact that, right? Payment parity. If after the public health emergency is over, if payment for telehealth services drops dramatically and practices haven't done anything with regards to restructuring, even, how they staff telehealth or their physical footprint in terms of their clinic space and things like that, then a smaller payment may not pay for what they have in terms of a structure.
Right.
They're fixed and variable costs. However, practices that look at it differently and look at it as a different line of business and how they want to staff it may still be able to do well with decreased payment. And I've used this sort of quote before, but life finds a way. In Jurassic Park, if providers, if physicians, if the payment decreases and they don't want to do these telehealth services, someone will figure out a way to step in and do it and make it profitable because there'll be demand for it. So really what you want to see if your practice is, let's keep our eyes on what we're doing and what's working right now. But let's say the payment drops again and there is demand for it. How do we staff that? One of the things that I think that the trap people fall into is protecting the past and what was versus looking towards the future. If you have a clinic space, and typically practices love to put clinics in the expensive part of town in the high rent districts, because that's where all the patients with the insurance are, and that's where the patients that pay their bills are, or whatever you want to say about that. That's what they do. And so with that comes a higher price tag for building space, right? And if you take a provider out of that system and now you have exam rooms, can you backfill that while this provider is out doing virtual visits somewhere, maybe from their home? Can you add another provider to practice in that space? It may not be the best thing to have that provider doing virtual visits from the office in space that you could be using for face-to-face visits.
Do you think, actually, let's bring up a good point, Ron. Like, do you think that the space required for medical practices is going to decline as we sort of see leases come for renewal? And do you think people are going to be downsizing their offices, especially in these sort of more urban, very expensive footprints that are downtown in big cities?
I can say that I think that spaces will be different. I don't know that I can say that it'll be downsized, because I think what you saw before the pandemic is, even as you started to see some practices moving towards eliminating the waiting room. And then, man, did that really escalate once the pandemic hit. Like, people don't want to be in a waiting room with other people
they
that
don't
potentially have COVID. So the concept of that going away, of where they come in, they register at the desk, and they're taken back to an exam room. Typically in that kind of environment, not counting what happened during the pandemic of people waiting in their cars with the restaurant style pager, you need more exam rooms for the provider to be efficient in that situation. You could downsize your waiting room, but maybe turn them into exam rooms. I think what will happen more and more post pandemic is there will be practices that don't want to add providers, could downsize their clinic space. They could give more exam rooms per provider to each provider so that they could be efficient, eliminate the waiting room, but also eliminate some space or relocate space for coding, billing, back-end office type of things that for efficiency's sake may have been in the clinic in the past, but may not be going forward. Because
Gotcha.
those are some type of employees that theoretically could work from home.
No, you're right. You're right. I mean, so it's really more reallocation of space rather than necessarily a downsizing of physician practices.
Exactly. Yeah, because really what you want to do is you want to, in a practice, you want to make sure that your most expensive resources are being as efficient as possible. And so that means potentially that's how the whole multiple exam rooms per provider kind of situation happens, is so that the provider can move quickly from room to room to room. Recently, though, and you've seen the movement towards patients not liking to wait, the importance of patient satisfaction scores, things like that, that there has to be a countermeasure to that with regards to, you can't make it like it used to be, where maybe a provider had 5-6 exam rooms and you fill them up with patients and people were waiting in the exam room for 45 minutes until the doctor got there. That's not acceptable anymore. So there has to be a balance, so that you're making sure that your most expensive resources are being incredibly efficient, but also that you're doing it in a patient-friendly way.
Yeah, I think definitely, the writing is on the wall, literally, I guess, for waiting rooms. I don't think there's going to be a lot of tolerance for that. And I think, as you said, even before the pandemic, I think a lot of people are realizing how much of a wasted opportunity that waiting room really is.
Right.
Um, I won't say it covered up for inefficiencies, but it was sort of the catch-all, right? It's like, oh, we have one of these, and now people don't want to be in them, and people don't want to have them.
Yeah, when you think about it, it kind of was a thing that practices were actually judged a little bit by the opulence or how nice the waiting room was. But the counterintuitive thing was people didn't want to be there.
Right.
Right.
Exactly right. That's kind of, it's the same thing as like the airport theory, right? Like, don't make the airport lounge very comfortable, because I actually don't want to be spending a lot of time there. I want to just go in, get on my plane, and get out, right? Like, that's essentially what, well, I might won't say all practices, but a lot of patients who have that kind of transaction with a healthcare system, that's what they want. It's all they're looking for.
Mhm.
And to that end, I think that's what people have found that works really well with telehealth, right? Where you can, have that quick interaction, that quick check-in, without the diagnostics right now, where, you can have that consultation and then get your questions answered with your provider.
But the waiting room is a virtual one, and I can actually be doing other things that I need to do while I'm waiting.
That's right. You can catch up on your email.
Yeah, exactly.
now, I actually, on the topic of that sort of diagnostics, that's sort of the missing piece that would allow even more care to be provided remotely, and that is the glucometers, the blood pressure cuffs, all those kinds of devices. They're not rolled out quite as at a high level as telehealth is. I mean, we had the 97% on telehealth, but your stat survey showed that only 21% of practices have rolled out a form of remote patient monitoring.
Right.
So,
There's I want to say three basic barriers to remote patient monitoring. The first being cost, and it can be cost for the practices to implement and be able to do this, but also for patients to do it. And that cost is also associated with, like consumer grade versus medical practice grade types of measurement devices too. The second one being, um, people are lazy. People, myself included, and to be able to rely on myself, other than maybe like doing a once a week reading or something like that, to be able to do any type of continuous monitoring or continuously report or make sure I'm always wearing my device and things like that. Is that going to happen? Is it going to happen to the extent that it needs to? We're a society that, like, no, I should be able to just go in once a month or once every 6 months with my doc, and they adjust my meds, and they measure me and whatever they need to do. And I shouldn't have to deal with all this crap. That's the type of mindset that we have. And then the third one is reliability of the measuring. So let's take blood pressure, for example. Blood pressure monitoring, if you're monitoring it in your practice, and let's say you have a quality goal around it, and you can actually get the average blood pressure of your team, or whatever, each pod, however you're set up for the patients in Dr. X's panel, down a little bit if you actually follow the guidelines and what you're supposed to be doing in terms of measuring, meaning sit them down, let them rest for a couple minutes before you take it, feet on the ground, back against the chair, arm elevated to a certain thing. That's just four of the things. I'm non-clinical, so I can't name them all. There's probably more, but if you rush them back, you do their weights and measures on the way back to the exam room, sit them down, throw the cuff on them as soon as they get there. They may already have their white coat anxiety type of stuff going on too. Their blood pressure is going to be higher. So you take all those things that could go wrong in measuring, and now you're saying every patient is measuring their own blood pressure with devices that might not be as good as what we have in our offices. Go charge. It's a recipe for not necessarily accurate results. So there are obviously lots of different remote patient monitoring types of things that you can do that don't have that type of variability built into it. But I think those are kind of the barriers that we're talking about. There'll be more and more of it, but there's still elements of, when you think about testing and things that you can't do virtually, you're not always, you may think of the testing of like, I have to go get an MRI, or they wheel in the EKG machine, or, that type of stuff. But there's also just the physical testing of, feeling around on the neck, looking in the ear, that type of stuff that you can't replicate. You may be able to do a follow my finger type of thing, but not a full neurological exam that is typically part of the physical.
Yeah, I mean, I totally agree with you. First of all, I agree that cost is a barrier, but I think it's a barrier that will calm down quickly, because as more vendors, as more docs, want these, as more patients want these things, they will come down in price. And I think because of that, I think overall telehealth will continue to expand its percentage, if you will, of visits, but it'll be a little bit slower than what we've seen during COVID, right? Where necessity drove a lot of the adoption. But I do think, to your point, Ron, that there are some simple things that could be done. If I just need a quick check-in of your blood pressure, or if you have a built-in glucometer, those kinds of things I can just do. If I can quickly just take a look and make sure you're within tolerance levels, I think that would be okay. I may not be able to make a complete diagnosis from what I see, and maybe want you to come in for a test, but there may be some simple things I can do with these kinds of devices that would, hey, save a few trips for a few patients a year. And to me, that would be worth it.
Absolutely. The preventative things there, if you can track something and once it's starting to go out of range, early detection helps out so many different types of problems that can go on. And, it needs to be a way though for practices to, not just the patients, but it needs to be easy for the practices. It needs to be easy, but maybe automated. Hey, you're due to send in your glucose, send us your glucose, or, whatever. So, because if not, then you're maybe having to add staff to continually be, looking through the medical record, who's due for, what do I need to get in terms of checks from various patients, et cetera. So.
Actually, that again, you're like leading the interview here today, Ron. But that leads me to a question I wanted to ask you around IT staffing. Traditionally, we've only seen sort of dedicated IT staff at the larger practices, the group practices, of course, at hospitals. Given that healthcare is going much more digital, we're going to have more remote patient monitoring devices. We're going to have telehealth, the waiting room technologies that we're going to deploy, all these kinds of things. Do you see sort of the need for practices to have more dedicated IT resources going forward?
I think so. I think that the smallest practices, even if they don't have an IT manager or an IT person on the staff, they will probably need to outsource and contract with it. Practice administration as a profession was, kind of born out of the person that was at the medical office that greeted people when they came in, and then eventually they had to start figuring out how to bill them and bill the insurance, and then contracting, and then HR, and then and then
So they kept getting more hats, is what you're saying.
exactly. And so in the smallest practices, they're also the IT administrator, and I compare this to, we have our not to plug MGMA in our products, but our certified medical practice executive is something that people who are administrators in smaller practices tend to, via their own words, have an easier time than administrators in large systems. And that is because our body of knowledge covers so many things, human resources, risk management, things like that, that administrators of practices in large systems, they have a human resources department. They have a risk management department, they have a legal department, they have IT, they have all those things. And so while they may know some basic stuff about it, they may not have as advanced knowledge as someone who has to live that and be the go-to person that then contracts with the vendors in the smaller practices. So it's a similar thing that, so they have to know it. And if they're not managing it, if they're not running the telehealth of their practice, they have to coordinate contracting with someone that can going forward. So yes, absolutely. Remote patient monitoring, telehealth. There's just so many technological things that are going to be part of practices going forward. And I think a potential thing, not to get political about it, I'm not going to, but if a federal minimum wage thing goes into effect for $15 an hour, that could theoretically impact practices and how they hire for certain staff, like you see in other parts of commerce. It's like, will there be more kiosks? Will there be more virtual sign-in and registrations and pre-work done, so that practices, in order to be able to live in that world, can hire fewer billing, coding, registration, front desk, whatever staff. So,
Well, actually, again, you're leading me on here, Ron. It's a perfect segue into this question. Do you think, given all the uncertainties of 2021, I mean, we've got a lot, right? COVID is still not past us, and there's a lot of other changes happening to the way people interact with healthcare. Do you think practices need to sort of reset how they're going to measure themselves and their success this year?
uh, yes, but is how I would answer that.
Okay.
So, the reality of healthcare and medical practices right now is yes, we can determine some of our own goals, but some goals are determined for us based on the contracts we sign, right? So, who knows whether it's the federal government or insurers who tend to sometimes follow the federal government, what types of goals we will have to do in the quality realm for the Affordable Care Act, gets strengthened and revitalized and whatever, if that goes on. So I think there will be quality metrics. I think there will be metrics with regards to the productivity of telehealth as you do it. And I think the smart practices will sort of figure out a way to separate those business lines, because especially if the parity, the payment parity goes away, you'll need to really view those in isolation. And so you always have to be thinking about what your goal should be in the environment that you're in, so that you can be moving forward to where healthcare is going to be and not where it's been.
And I know you do these stat updates regularly, but is there anything that you're looking like you're predicting or that you're anticipating this year in terms of something unique or something that will be going, that was cool?
Well, the unique and that was cool are two different things.
Okay.
I think that what we're going to see is one of the things that will really be memorable about 2021 is the emerging from the pandemic changes, where, dialing back down telehealth a little bit, and the effects of payment parity, the demand, the backlog of patients who deferred their care during the pandemic, due to safety concerns. Which one of the things in there in our stat article was most surprising to me was that 87% of patients deferred care due to safety concerns. I tell people all the time, is like, where should be safer than a physician's practice office? They literally take an oath that says, first, do no harm.
Mm-hmm.
And arguably, physicians should be able to have an even greater impact on the environment and the care and everything and safety in their own practices, even more so than they do in a hospital or any place else that they might be. So it should be safe. I think maybe what we didn't do as practices is convince patients that it was safe to come back into our offices when they were allowed to do so.
So a bit of a communication issue and a communication challenge of getting the word out there to say, hey, it's okay.
Right. The difference is, I would describe it and you can use some simple phrasing to talk about it. And early on, I jokingly will say that all the healthcare commercials on television, radio is like, we're all in this together in these uncertain times. Whatever, the same stuff is being said by literally everyone. Until about a month and a half in, I saw my first commercial that said, these are the things that we're doing to make sure that you are safe, and how we're doing them. Come on back, basically. It's safe to be here. And that, differences like that in being very specific also show up in other types of surveys. And one of the surveys that I like to reference is, I think it was Gallup, may have been Press Ganey, I'm sorry if I don't know which survey company, did a study where a health system was working on the patient's perception of the staff's concern for their privacy. And the staff at the hospital, they made one change. They said, as they were drawing the curtain close, I'm pulling this curtain close for your privacy. I'm doing this for your privacy, or whatever. That's all they did. And the scores with regards to the perception by the patients of the concern of the staff for the privacy went through the roof, right? It's not that they did anything differently. They managed, and they were very clear in saying what we're doing to make you safe, to make you feel like we care about your privacy, whatever. The spoon feeding.
So yeah, so in other words, it's keep doing what you were doing, and they've been taking care of patients for a very long time. But it's really more just highlighting, both on a one-to-one basis, but also publicly, hey, these are the precautions we normally take when patients come in. We want to
Because we
keep
care.
you safe
Yeah, because we care.
because
Exactly.
we care. I like that. We can make our own commercial here
Yeah,
just on
these are
this.
the exact things that we're doing because we care.
I love it, Ron. Maybe as a final question, I'll ask you this. If you had one message that you can give to practice managers and physicians everywhere who are listening to this interview and reading this article, what would you tell them?
I'd love to just say this was our chance to hit the reset button. Let's look at what healthcare should be instead of taking the opportunity as soon as we get the chance to go back to what it was. Let's make it what it needs to be, and do what the patients want, help them get there, help them maintain their health. Because this was a big reset button for us, and I think that we have an opportunity to do there. Physician practices can and should be a very large part of that, maintaining their health, and then be ready for the influx that's going to come. Those of you in the subspecialties of the patients at deferred care, because it's building up, and at some point in time, the release valve is going to be open. So.
I love that. Get ready and that big reset.
Yeah.
I love those messages, Ron. Thank you so much for taking the time out of your very busy day to be with us here on Healthcare IT Today. Really appreciate it, Ron.
Yeah, glad to do it, Colin, anytime.
This has been Colin Hung at Healthcare IT Today with Ron Holder from MGMA. Thanks for listening.